Hello and welcome to PHM 6110. My name is Dr. Florida Uzuaro and I am your instructor for this course. So, we are starting off with discussing the economic and political dynamics of the US health system, health service, and we are going to kind of, with this course, is more or less like an overview of the US healthcare system. A lot of what we're going to talk about this course you have already been, taught or a little more familiar with in taking other courses in population health. So a lot of what I'm going to say here is not going to be completely new to you, just to let you know. But this is more or less like a way of starting before we get really into the course. So, with the course, we have three learning objectives. We're going to start by analyzing the factors that are influencing the healthcare system in the US, look at structure, external forces, power dynamics. We're also going to look at perfect market imperfection. And then with the second learning objective, we're going to look at corporatization of the healthcare system and the impact it's having on health delivery. And then last, we're going to discuss globalization of healthcare, look at global health challenges and reform efforts. So for this lecture, I'm going to break down the lecture into three different videos so that it doesn't get too long. You can watch the first video that is going to look at the first learning objective. The second video is going to focus on the second learning objective, and then the third video is going to focus on globalization, which is the third learning objective. So just to let you know that the entire lecture has been broken down into three videos so that you can watch one after the other. So let's get into the first learning objective, where we are going to look at the overview of the US healthcare system. So there are a couple of characteristics of the US healthcare system that you kind of need to know. First is like it is very, very fragmented. Care delivery is spread across multiple uncoordinated systems. You have the primary care providers, you have the specialists, and you have hospitals and post-acute facilities. I remember the first time that I came into the US and discovering that there is emergency services is very different from urgent care, and it was so very confusing to me because I could not understand why they are not the same thing. Why do you have emergency service separate from urgent care? Because in my mind, every emergency service is urgent, so why does it have to be separated? A lot of that has to do with the fragmentation of the healthcare system, the US healthcare system, and the way that things have just been broken down into tiny, tiny pieces that makes it very, very difficult for consumers, for instance, to kind of have a good picture of what is going on. So what happens with this fragmentation is there's a lot of inefficiency and a lot of duplication of services, and it also leads to there being a lot of gaps in care transitions, and not a very good communication that is happening between providers. If any of you are on my chart, you may have noticed that my chart is kind of provider specific. I remember when I was in St. Louis, I was in a hospital, completely different hospital. We had my chart. And so moving to Louisiana and had to register in a different hospital, they are also on my chat, but we're in a completely separate login and system, and they were not talking to each other. So if I needed document from the services I received when I was in St. Louis, I had to log out of the service, from Louisiana's system and log into the St. Louis system just to get information out of it. So it is convenient in the way that they were all in my chart, but they were not talking to each other. So this leads to misalignment with communication between providers, and this can happen in the sense of you having a discharged patient with heart failure and not having a very good coordinated care. Imagine if the person is going from a different state to a different state, and the going to a different state to receive services, and then they had to come back to their home state, and there is very poor coordination with the care follow-up. So that kind of causes a challenge. Another challenge, another characteristics of the US healthcare system is that it has a hybrid financing model. If you guys are familiar with the healthcare models, you have the Bismarck and you have the insurance, national health insurance system like the UK with the NHS and Canada. The US is very interesting in the sense that it has both the private and the public. So, and they are all both existing, having just as much impact on each other. So, you have the public programs, the Medicare, Medicaid, and you have the VA. So, they are very much serving a reasonable big proportion of the citizens. They are serving a lot of people, but at the same time, you have the private insurance that are covering a lot of working age adults, and they're doing this through the sponsored plans. And within them, they have, there is a high deductible health plan and the low deductible health plan, which is not very easy to kind of figure out which is which. What is covered under high deductible versus what is covered under low deductible is a very, very opaque system in that sense. And those are some of the things that come in that get all of this information. But however, regardless, a lot of the times, whether you are private care, you're in public program, or you are in private program, or sorry, private insurance, or if you're uninsured, you still have a lot, quite reasonable number of amounts of money that goes as out of pocket spending. That would be, you could be doing so as a co-payment or as a deductible, or for those who are uninsured, who are having to pay everything out of pocket. And all of this creates a financial hardship, especially for families who cannot afford that. And then you have the regulatory bodies, the FDAs and stuff, and you have the state governments that oversees Medicare, Medicaid administration. So there's a lot of people that are, in the US healthcare system that are all having a lot of influence and impact on it. So, speaking very, just going into the structure of the US healthcare system, you have the providers, those who are providing care. And one of the challenges, one of the uniqueness in a way of the US healthcare system is that there's, especially for providers, there's a thing called consolidation trend. What happens there is that you have hospitals and health insurance and a lot of providers that are merging with one another, and this is happening so much more going on. And what happens that they create this large system that dominates regional markets. So you may find that in one part of the state, there's mainly only one provider of healthcare. Remember when I lived in St. Louis, every hospital system that I knew was part of the St. Louis University Hospital. So I did not, for the 3 years that I lived there, I did not see a single hospital that was not part of that system. And in Hammond, right, also, there's a lot of, different providers, that a lot of them are under North Oaks. So there's a lot of hospital mergers that is happening, and they dominate a large portion of the market, and makes it very difficult for people to move around and go somewhere else to kind of see what's happening. So what happens with that is that there is a reduced competition in the market. So you find one large provider, hospital merger, who decides this is how much we're going to charge for a service. And for consumers, they don't have the opportunity to go elsewhere and figure out if they're going to get something cheaper. So that reduces competition, and therefore prices get to be decided by the corporation that has taken over those, with the hospital mergers. So that does bring some challenges. So we have the 2021 study that found that hospital consolidation has been associated with 12% increase in prices without any significant quality improvement. So you have prices going up and your quality is staying about the same. And much of that goes into because there's reduced competition, you know. So and then you have the payers. The payers, you have the public programs, with Medicaid covering about 18%, and Medicare 18%, and Medicaid 21%. Medicaid eligibility, which when the Affordable Care Act came in, there was a lot of, you know, things that changed under it. But even with that, there's still a lot of variability with that. So you have the states that expanded Medicaid and the states that did not expand Medicaid. But even within the states that expanded Medicaid, the benefit and eligibility is not across border. So some states have very generous benefits under their expansion programs, and some states not so much. So it's very it varies a lot, which can lead to coverage gaps, depending on whether you're in a non-expansion state or you're in an expansion state. So, talking about the key challenges, structural challenges, I have kind of mentioned a little bit of this as I was talking, but I just kind of want to focus on it fully. Coverage gap is a big problem. The Affordable Care Act addressed a lot of that, but the problem still persists. And a lot of people who are affected are people who are in non expansion states, who were not able, some of the achievements of the ACA, they were not fully able to, buy into that. So you have a lot of low income adults in non-expansion states that still do not have, coverage, even with the ACA being around for a long time. And then you have the immigrant population and part-time workers who often do not have employment based insurance. So, and when I say immigrants and part-time workers, I do not mean illegal immigrants. I mean those who are in the US legally, but they are not they're not employed by organizations that provide healthcare insurance. So the only option of getting healthcare is either they get one from through Medicaid or through the health insurance exchange, or they pay 100% out of pocket. So that still brings the problem of coverage gaps. And as of 2022, the study found that 6.8 Americans are uninsured, which may not sound a lot, but when you look at it in terms of it's 27.5 million Americans, that's a lot. 8.6 doesn't sound like a lot, but America is very large. 8.6 is 27 million Americans, which is a lot of people to not have insurance, especially considering how expensive the U.S. Healthcare costs. So, what then happens with it is that uninsured individuals end up delaying care and then waiting until their things get very very serious, and which then lead to it being so much more expensive. So that is a challenge is a structural challenge with the healthcare system. And then there is administrative complexities. Like I mentioned, there's a lot of players in the US system. You have the providers, you have the regulators, and you have the patients. There's a lot of people with a lot of interest in it that leads it to it being very complex. So this multi-payer system brings in a lot of complexity in terms of billing, in terms of claims, which increases administrative overload. And the fragmentation in documentation and coding also adds inefficiency. So administrative costs in the US accounts for about 25% of the US national healthcare expenditure. This is compared to 8 to 10% by for single payer systems like the UK with their national health insurance and stuff like that. Because of the fragmentation of the US system, like I said, is hybrid. You have the public, you have the private, and then all of that, the uninsured and stuff. So this complexity leads to a lot of administrative costs. So The US also has a very big challenge with there being an over emphasis on curative services, which uh, um, drives up the cost of healthcare in the US. For instance, um, chronic conditions like diabetes and stuff accounts for over 90% of Medicare spending in the US, with the top 5% of patients under Medicare having four plus chronic conditions and accounting for 30% of all chronic disease spending. So there's a lot of money that is going into curative services, and a lot of these diseases are health lifestyle based, and yet you would think that there would be a lot of financing that goes into prevention, for example, with the early intervention and preventive services, which is known to significantly reduces this cost. However, they are very, very much inadequately funded. And therefore, even though they have this potential of really, really reducing healthcare costs, so it is a big challenge with the US healthcare system. So a lot of what drives both the inefficiency within the U.S. healthcare system as well as the administrative cost of it is the power dynamics that exist in the healthcare system. Like I said, multiple key stakeholders. You have the government who are, both taking care of Medicaid, Medicare, and regulating and overseeing care delivery and all of that. They are there, being a very key stakeholders, and you have insurance companies that are, covering the treatments, paying for the treatments that are covered and negotiating reimbursement rates and all of that. So they're very big key stakeholders. You have the providers as the clinicians, as well as everybody who works in the healthcare system as a personnel. Those are the providers, and they do try, a lot of them try to advocate for fair reimbursement, not all the time, and trying to also push for operational resources. And then you have the pharmaceutical technological companies that are driving innovation, which is good on one part, but also having the problem of being monopolistic in terms of how they do their pricing practices. So they and all of these stakeholders have a lot of interest, their own interest in terms of wanting to get things done and what it is that they're trying to get done. And then you have the patients, that are also demanding affordability, transparency, and equitable access to care. And you can imagine possibly the least powerful of all of these stakeholders, but they're still there and they're still doing their thing. And there's a lot of power imbalance. A lot of that is coming from, like I mentioned before, consolidation of, hospital systems. This is not just happening with hospital systems. Insurance are also consolidating within themselves, all of which is leading to, like I said, lack of competition, which then happens with increasing consumer costs. The large insurance are dominating the private insurance market and leaving patients with very little choice. And some of what is happening, especially with the employment-based insurance, which, like I mentioned before, is being covered by the large population of working age Americans and adults in America, is that once your employer locks in into one insurer, it kind of stays there. You either buy into that insurance or you go and buy on your own, of which part of that money that they would have paid into the health insurance, they will not contribute that towards you paying it so for a different insurer than the one that they are contracted to, which means that if you do not have another place where you are getting your insurance, you're kind of limited to staying with the insurer that your employer has bought into. So that is a problem, that it limits patients' choices and also limits their negotiating power. And then in the US, these three insurance that are much very much in control, and also when you consider that a lot of people are part of that insurance group, they have a lot of power in terms of deciding, what happens and what doesn't happen. Another problem with this, especially with the consolidation of power, is that they are able to, really organize their lobbying efforts from the interest of the corporations. And lobbyists have a lot of influence on health policies, and health policies have a lot of influence on health outcomes. So when you have these corporations putting a lot of effort into lobbying to have health policies that benefit them, it does have a problem where you see industries are being prioritized over the health of the public. So this is one of the things that bring about power imbalance. Same thing happening with insurance pharmaceutical companies spending a lot of money with lobbying in the US, making sure that health policies protect their interest and also leave it able for them to keep on making billions of in profit. So, and what happens, some of the things that contributes towards these challenges with the US healthcare system is because the US healthcare system is what is called as an imperfect market. So the US healthcare system is very much market based, but it's in an imperfect way. In a perfect market, everybody gets to know what it is that things cost, and you decide whether you want to buy this or whether you want to buy A or you want to buy B. The US healthcare system is market based, but in an imperfect way. So the characteristics of an imperfect market is that there is information asymmetry, which means that patients lack sufficient information to make informed choices. Market in terms of, okay, let's say an iPhone or an Apple product. I would know how much an Apple product costs before I choose whether I want to buy it or not. It doesn't happen with the healthcare system because there's a lot of information asymmetry. The patients, who are in this case the clients or the consumers, do not really know how much things cost, the healthcare costs. Even some of the times your provider would say it depends on the, after the insurance have said their own and decided, okay, this is how much they can cover, that's when you will know how much that is up to you to cover. So it's very, very complicated. And this information asymmetry leads itself into the US healthcare system being an imperfect market. And there's also price inefficiency that creates these variations. I remember when I was lived in St. Louis, and I had Aetna. My insurance was Aetna. Then I moved to Louisiana and moved to Blue Cross Blue Shield. I was very, very surprised to find out that my out of pocket payment for my medication was very, very different on the Blue Cross Blue Shield versus Aetna. The same medication, I had not changed medication, I had not increased dose, I had not changed brand. The same medication had very, very different out of pocket payment depending on the insurance that I was under. So this brings a lot of wide variety, variation in terms of what things cost, and even less transparency for consumers, because you how much you pay depends on so many multiple factors that you are not able to. And it's usually when they've given you the service and say, okay, bring this. And sometimes you don't even know how much until the bill comes. And that leads to pricing inefficiency. For example, procedures for MRI varies a lot in prices, depending, even if it's within the same geographical area. A lot of that has to do with who your insurance is and what type of health plan that you bought into. And this lack of transparency really prevents patients from shopping for a cost-effective care. So this problem, I already talked about consolidation, but also the information symmetry and the lack of transparency all makes it very, very difficult for patients or for consumers to fully make informed decisions about whether they are going to receive a healthcare service or not. So, therefore, this, even though the US system is said to be market based, it's not really market based, because some of the characteristics that is expected for it to function as a full in a full market does not exist, whether deliberately or not. But this is that, and I've already mentioned consolidation of providers and insurance, and what that happens in terms of getting reducing competition. And then you have the third party payment system that disconnects payers from users. And I'm going to use an example of when I had to go to the hospital and I needed ambulance services, and then an ambulance came, and then a few weeks later I got a bill, and I was very, very confused about that, because from my experience, hospitals have ambulances, and when you need when you need to go to a hospital and you can't bring yourself there, the hospital sends the ambulance. So when you're being charged by the same hospital that treated you. It was so very confusing to me that there was a completely different person that was in charge of ambulance versus the hospital. And so when they sent me the bill, the amount of money was crazy. I was like, What's going on here?" And so I contacted them, and they said I should send them my insurance card. I sent them my insurance card. It came back and said they didn't receive it, that I had so and so time to pay. And I didn't have to call my insurance, and my insurance said, okay, I can call them to call them. So all of this very, very disconnection in terms of, the payer, the insurance, and the user leads to inefficiency and a lot of overutilization. Imagine there's possibly more than one user that is calling the insurance company to say, hey, I received this bill, what's going on? So all of that leads to, not a very good system. So consequences of this, imperfect markets of the U.S. healthcare system is, as rising costs, healthcare that disproportionately affects low-income population. You have the persistent disparity in access, especially affects low income or those who are in underserved areas. There's very limited incentive for corporations to spend money into primary care, especially in underserved sectors who are not going to pay them those, thousands and thousands of dollars for it. So, in summary, the US healthcare system is very complex. There's a multi stake network, and the stakeholders, you have the provider, the payer, the regulators, all of them having very, power in it. But it does have a purpose, at individual levels, delivering timely healthcare. At population level, is promoting, public health through prevention and chronic conditions management. But also very, very, it feels as if I've spoken so much not so great things about the US system. It does have some positive, one of which is being that it is a global leader with medical innovation and technological development. So far, the US is leading in terms of medical innovation. So that's a positive part of it. I mean, it does have a knock on effect in terms of disparity, but on that end, it's doing a very great job for it. And I also mentioned some of the key challenges in the US, the uninsured and the rising costs of it. So that is where I end with the first learning objective. We're going to look at the second learning objective, when